with these medications. So the first group that I'll start with are the statins. It's a very colorful slide. Hopefully serves as a quick reference for you to be able to see what statin your patient's taking and then what direct acting antiviral or DAA that you're going to use. So the drug interaction specifically, what we're concerned with is the DAA is causing an increase in the concentration of statins, leading to statin toxicities, most notably the myalgias that we see. So the recommendation is that you can do a handful of things. You can either change the statin to one of the ones that does not have an interaction with your DAA, or you could lower the statin dose if that's one of the recommendations. Or if you're comfortable, patient doesn't have a significant cardiac history and you feel okay with having the patient hold that statin, they can just hold it for the 8 to 12 weeks while they're taking their DAA to avoid the interaction completely. So you do have some workarounds and some options. And as far as the chart goes, in the orange, you can see where I've highlighted some of the max doses. So if your patient's on a higher dose, you could lower it down to one of these doses. In the red is where it comes up specifically that it is not recommended to co-administer with that specific statin. And then the yellow that you can see on the slide is usually the lowest dose is what they recommend, or just to monitor. As a practitioner, I don't know how you know what the lowest appropriate dose is when you're worried about a drug interaction. So usually what we just do is monitor, educate the patient, let them know this is a drug interaction. What we're concerned about is the myopathies. If you start noticing the muscle aches and pains, give us a call and we can talk about changes at that point. So usually at that point, it's just monitor. I want to highlight too, I'm going to go over some of the resources at the end of the slide as far as knowing what the drug interactions are and finding those quickly. These are all specific to the package insert in the United States. So you may see some variability if you use like the Liverpool website that I'll go over, but these are all in are affiliated specifically with the United States package insert recommendations as far as the lowest doses that are recommended and whether or not to use them concomitantly or at all. So hopefully this is a quick reference for you to be able to quickly, like I said, look at your patient's statin, what DAA you're planning to use, and figure out what to do here in the middle. The next big one that we see a lot is acid suppressing agents. And the reason for this is that the increasing of the gastric pH, which is the goal, we want to make it more basic. That's why we give them those therapies. It decreases the solubility of some of the components within Harvoni and Epclusa. So what it is the NS5A inhibitors that are in those groups. So the lidiposphere and the velpatosphere specifically in those drugs, as well as with Vosevi, the velpatosphere in that. So it essentially, we get lower concentrations absorbed, lower therapeutic concentrations, and we're worried about virologic failure at that point. So we have a couple of options here as far as what to do to avoid those. So you could use not Harvoni or Epclusa or Vosevi. You could use one of the other agents that we have available. Other options are, if the patient is willing, they could just hold their acid suppressing agent, and patients will surprise you. I've been surprised. A lot of patients are like, yeah, I'll just hold that. I'll power through it. I'll have some symptoms. I'm not worried about it. So they may be willing to hold whatever that DAA is. I'm sorry, the acid suppressing agent is while they're on the DAA for 8 to 12 weeks. Or we could adjust the dose. And that's what I have on the subsequent slides here, is how to avoid those with appropriate doses of acid suppressing agents and the appropriate administration to educate patients on how to avoid that interaction. So this table, this slide is specific for Harvoni. So what you can see is the acid reducing agents, so antacids, H2RAs, and proton pump inhibitors, and what to do. So because the antacids are short acting, they don't stay in the stomach for very long, don't have that long mechanism of action, we can avoid this by separating from Harvoni by at least 4 hours. So what I like to do is usually just say, when do you have heartburn or reflux? When do you usually take Tums? And if they say, oh, usually it's sometime after dinner, okay, well, why don't you just take your Harvoni with your morning routine? Then you avoid that interaction completely. So usually just trying to find time that they're not going to usually take Tums, Rolaids, Maalox, those sort of things, and completely avoid that interaction. But it's at least 4 hours, and they can safely administer if they separate by that time frame. It gets, as we go up in the duration of action for the acid suppressing agents, that's when we have to kind of make more of an adjustment. So for the H2 receptor antagonists, the recommendation is a max dose of famotidine, 40 milligrams twice daily, or a comparable dose. So I have the ranitidine here for completeness if it ever comes back into use. But the famotidine 40 milligrams twice daily, and the patient can take the Harvoni at the same time or 12 hours apart. And really that gives you the wiggle room if they're only taking it once a day versus taking it twice a day. So if it's once a day, same time, or 12 hours apart, if they're taking the famotidine twice a day, they're going to have to take it at the same time. And that's just, again, because of that duration of action of the famotidine. And lastly, the proton pump inhibitors, this is where it gets a little bit more complex. The recommendation here is max dose of omeprazole 20 milligrams once daily or a comparable dose. So I have some of the other PPIs listed here at those comparable doses for reference. And the patients will have to take the Harvoni and the omeprazole at the same time on an empty stomach. So because of that longer duration of action, the omeprazole needs to be taken at that same time with the Harvoni to avoid the interaction. And from there, we'll talk about Epclusa, which by and large, the antacids and H2RAs are the same information to avoid that interaction. What differs here is the proton pump inhibitors. So here, the max dose is still omeprazole 20 milligrams once daily, but they didn't study it, and it's not recommended to have a comparable dose with any of the other PPIs. So the recommendation of the package insert is if they're on a different PPI, change them to omeprazole 20 milligrams once daily as the max recommendation. Now, if you read in full detail in the package insert, it'll tell you don't use a PPI at all. Change to an H2RA or see if they can hold it. So it's only if it's medically necessary to use a PPI. But if they need to take it or they can't come off of it because of symptoms, then the omeprazole 20 is where you're going to have that middle ground to avoid the interaction. And the recommendations here are a little bit different than Harvoni because the recommendation is that the Epclusa should be taken with the omeprazole with food. And then the omeprazole is, I'm sorry, the Epclusa is taken with food and the omeprazole is taken 4 hours later. And this is not at least 4 hours. This is a recommendation of specific 4 hours later. So what I usually try to do with patients is try to get them on a schedule where that they can try to make this work and keep track, because a lot of times they hear 4 hours later and they think, oh, well, then I'll just take the omeprazole at night. But the way that they looked at the pharmacokinetic data and the best way to avoid the interaction where the omeprazole doesn't interfere too much with the Epclusa concentrations was the specific 4 hour window. So I usually say, okay, take your Epclusa, you're going to take it with breakfast in the morning at 8 o'clock, and then you're going to take your omeprazole at noon. So they have that specific window set up and set them up for success. So they truly understand that that 4 hour window is really important to try to stick to as close as they can to avoid this interaction. So it does make it a little bit more difficult from a scheduling standpoint and a change in routine while they're taking this Epclusa for that 12-week period. The next drug interaction that I want to talk about is ethanoestradiol, which is the estrogen component in pretty much all combined hormonal contraceptive products. And the drug interaction, where most frequently we see it with Mavyret, but it's also a concern with Vosevi and Vicirapac as well. And our concern is that we can see ALT elevations. And there's updated information here on this slide that I think happened somewhere towards the end of the year last year. I want to say it was in October. I can't remember the time frame specifically, but recent development. It used to be no ethanoestradiol at all with these agents, but they had done some subsequent studies and found that if the ethanoestradiol component of that oral contraceptive is 20 micrograms or less, then they can be safely co-administered. But once it goes above 20 micrograms, then we're concerned about that ALT elevation, and the co-administration is not recommended. So in that same vein, as far as what to do if your patient's taken one of these medications, is use a different DAA, a different agent that doesn't have the drug interaction. Try to change them to a product that has less of the ethanoestradiol, so it meets that 20 mics or less, or they can hold it completely and practice abstinence, or change to a progestin-only contraceptive. So there are a whole slew of progestin-onlys that a patient could potentially use, from the oral pills to the long-actings, for anywhere from the depot, the implant, or the IUD, which are all progestin only and safe. So we do have a couple of options to avoid this interaction, even more so now because they did find that difference in the concentration of that ethanoestradiol to give us a little bit more wiggle room for that interaction. And then we'll transition here to the antiarrhythmics. And I bring these up for two reasons. One, because we know that digoxin is kind of a pain as far as its therapeutic window goes, and how we have to monitor that pretty closely, because small changes in dose and those drug interactions can have big changes as far as the drug and reaching toxicities. So the recommendation is for Harvoni, Epclusa, and Mavyret that you want to monitor their dose, their levels while they're taking the agent. There is a potential for interaction there, so we can see some changes with that DIG concentration where we want to make sure we're making adjustments while they're on treatment appropriately. But we don't see that interaction with Zepatier. We don't have any expected interaction, so we wouldn't have to do any extra monitoring as far as digoxin goes. The amiodarone, though, is a different story because of the black box warning that came out after Harvoni and Epclusa were on the market for a little while. And what it was that we saw several case reports when patients were taking sofosbuvir-containing regimens and amiodarone of life-threatening bradyarrhythmias. There was, as far as the case reports go, at least one death and a patient that had to have a pacer put in place. So they did have recommendations where you could admit the patient and monitor them when they start the sofosbuvir-containing regimen. That seems kind of overkill. I think our easiest option is to change to a different DAA. If you wanted to change the amiodarone to a different agent, depending on what it's being used for, as far as arrhythmias or heart failure, you could do that. Just remember that amiodarone has a really long half-life. Usually the estimation is somewhere in the neighborhood of 2 months, and that'll be even more prolonged if a patient has liver dysfunction. So if you're going to change the amiodarone to use one of these agents, you're going to have to wait probably a couple of months just to have that half-life decrease. Now, the package insert doesn't have any specific recommendations on how long to wait after that stop, so you'd have to have a general idea of where you're comfortable with starting before initiating the DAA after stopping that amiodarone. So that's something to be aware of from a pharmacokinetic standpoint. And more good news, we do see patients that are on medication-assisted treatment in those programs. And as far as the direct-acting antivirals go, the naloxone and buprenorphine single or combo products are all safe. So is the naltrexone, and so is the methadone. So as far as drug interactions, no clinically significant interactions here that would warrant any dose changes or additional monitoring. And along those lines, I always like to throw in the drugs of abuse, just because if someone is using these recreationally and you're aware of it, just wanting them to know what to be mindful of as far as drug interactions go. So I have it in here from a completeness standpoint. So you can see on one side of the slide here that there's, as far as DAAs as a totality go, no clinically significant interactions with amphetamines, cocaine, heroin, ecstasy, cannabis, or LSD. The caution I have on here, and this is an abundance of caution with Mavyret and Zepatier, is because they do have some metabolic inhibitory action, and as that applies to fentanyl, GHB, oxycodone, and hydrocodone. So you may see the concentrations of those agents increase. So of course, we're worried about those also having a narrow therapeutic index and that risk for respiratory depression. So a couple of things to note here. From a fentanyl standpoint, I think it really warrants the awareness that I think we're all aware that there's a high variability in the amount of fentanyl that someone can see from a recreational use standpoint. So if somebody were on fentanyl that was prescribed, I wouldn't expect to see major changes. There's that slight, that chance of increase, that theoretical risk. I think more of the caution is, yes, there's that theoretical risk, but also there may be a lot of variability in the product that's available on the street. So just cautioning patients that there could be, a double whammy essentially from that to be cautious of. And it's kind of similar for the rest of these. And I also want to highlight oxycodone and hydrocodone also go through hepatic metabolism or liver metabolism. So the problem there is also that there's a caution in patients that have liver dysfunction, where the mechanisms of action of those could be prolonged as well. So it's a theoretical risk. From a prescribed standpoint, I wouldn't necessarily have big concerns if patients are taking any of these where I would warrant a prior to start an a priori sort of dose reduction, but something to be aware of if these are used recreationally, so the patients can have the most information out of an abundance of caution. And as we continue on here, I have the anticonvulsants listed. I like to bring these up because this is the easiest slide to make, because we've got this, lots of red on here that we see. And these are used not only for seizure control, but also mood stabilization and in bipolar. So we do see use of a lot of these agents. So carbamazepine, ops-carb, phenytoin, and the barbiturates are all enzyme inducers. So what that means is, from a metabolism standpoint, they speed it up. So the DAAs get essentially metabolized or chewed up faster. So we have subtherapeutic levels, which means we could fail therapy. So at current, the recommendation is to try to change one of these top 4 or 5 agents here to a different agent, because of that that induction that we know happens with these medications. I also tried to list some of the other anticonvulsants on the slide here and highlight that they're in green, because we do have options as far as that changeover goes. I have the more data soon question mark on here, because there have been a handful of small studies, and they have been pretty small. Most of them, I think, were under 10 patients that were involved in the studies. And they did, because the patient, for whatever reason, could not come off one of these enzyme-inducing agents. So they went ahead and treated them with regular dose DAAs. So they didn't increase the dose of the DAA. They just treated them with those DAAs and found that they still achieved SVR. So I think we're going to need to see more of these studies before they're confident in changing the package insert. But the labeling and the reason for the red on here is that the package insert says don't co-administer these at all, because of that interaction and the potential for virologic failure. So that's why they're red now, but just be aware. I'm hopeful we'll see more data come out on this, just so that we can have a better idea of safety as far as administering these together, and whether or not we'll have success for HCV treatment. Because right now, if the patients are on these agents, they don't have a treatment option for a DAA. But changing over to some good news, as far as antidepressants and anti-anxiolytics, the agents here that I have listed, no clinically significant interactions with any of the DAAs, and our SSRIs, our SNRIs, our benzodiazepines, or our tricyclic antidepressants. So as far as those go, no dose changes that we need, no major monitoring risks or concerns with the DAAs and these agents. This is a chart giving full credit to Angie from RDT. She actually made this slide, and I've commandeered it to use in this talk as well. So a whole list of the anti-psychotic agents that are listed here. A lot of green, so good, not a lot of monitoring or concerns with them. What you do see as far as the yellow and the arrows is that the DAAs actually can increase the antipsychotic agents. So these are yellow. We don't see any red. None of them are not recommended or contraindicated. At this point, it's all just monitoring for some of the side effects and things that we may see depending on the agent. So if there's CNS depression, increased sleepiness, or increasing activity, those sort of things. As far as like the long-term effects that we can see with these agents from a metabolic standpoint, that's not a concern, because you're only going to be taking them concomitantly with the DAAs for 8 to 12 weeks. So these are more of those short-term things where we may want to monitor them. But I can tell you that I've had plenty of patients that have taken one of the DAAs with aripiprazole, paliperidone, lorazepam, olanzapine, risperidone, a whole litany of these agents, and tolerated them just fine, didn't notice a difference. So at that point, it's just monitoring, letting the patient know what's alarming, when to contact you as far as the potential for this drug interaction goes. And next, the anticoagulants and our antiplatelets. A lot of yellow on here, and a lot of the risk is theoretical. And as far as monitoring goes, it's education for the patient to know signs and symptoms of having a bleed. The only agent where we have concern is dabigatran when it's given concomitantly with Mavorite. And I have not recommended /dose adjustment, because it depends on the resource that you use. So again, the Liverpool site that I'll mention at the end, the European information is, it says not recommended. The US package insert is a little bit different. It depends on the patient's renal function. That's how they kind of have that dose adjustment. So if they have renal impairment where their renal function is low, they'll say lower the dose from 150 to 75 twice daily while they're on therapy to avoid any bleeding. So it depends on where you're practicing. We're all here in the United States, so that would be the recommendation that we go to because of what's in the package insert. And then this actually is a chart that I did not make because why reinvent the wheel? This is a snippet straight from the guidelines. This is antiretroviral agents, and you can see that they laid this out really nicely in the guidelines so that you can see what the patient's taken from an art therapy standpoint to the direct acting antivirals with the green for no issues to the red to avoid. And the main caution that I highlight on here is that I like to point out on here is lost on my slide is the tenofovir that we see. And the primary and tripped over the primary concern is going to be with TDF. But we don't have that same concern with the TAF as far as the formulation goes, because the concern is increasing TDF increases our risk of renal failure and toxicity in patients. So we don't have that concern with the TAF formulation of tenofovir. But otherwise, this chart is a nice reference because you can go through here and see, okay, what's my patient taking, and I can pick their DAA based on what's not going to interact with the art therapy. So you don't have to change anything to their HIV therapy prior to starting for Hep C. And then at last, as far as the drug interactions go, I always like to highlight herbal supplements. Lots of patients want to take herbal supplements, use natural remedies for things. So usually, by and large, what I tell them, because there's not great information, is if you don't need to take it for 8 to 12 weeks, I'd rather you not, just because we may not have the information. These agents aren't FDA approved. They're not usually studied in those safety studies, so we don't have a lot of good information. And I can't tell you whether it will or will not impact the efficacy of the medication you're taking for Hep C treatment. And I can't tell you if you're not going to have side effects when they're taken together. I don't know. So if you can avoid it for that 8 to 12 weeks, please do that. St. John's wort is notorious. It's probably in every package insert for every drug ever, because we know it's an enzyme inducer. So it's going to have a similar interaction as we talked about with the anticonvulsants, where it's going to chew up the DAA that we're using and make it potentially less effective. So its use is contraindicated. We have a little bit of data for things like melatonin, milk thistle, grapefruit juice, and turmeric, where we don't expect any significant interactions. So those ones, if patients are taking those, I'm a little bit more lenient, because we do have some data available that says that might not be that big of a deal. So those are the specific drug interactions that I wanted to highlight today. I also wanted to highlight the resources. If you're not aware of these, you've got lots of great options. LexiComp is always good. I do realize that sometimes you have to have a subscription for that, and you may not have that through your institution, but it does have some drug interaction capabilities to be able to look for DAAs and what your patient might be taking. If your patient has HIV, the NIH HIV info has a good section on concomitant therapies and drug interactions. And I mentioned earlier the Liverpool website. So this is a snippet of where to find it on in your Apple or Google, as far as being able to find it in the store. So this is what it'll look like. And this is what it looks like when it opens up. It's a free app, I'm pretty sure, because I'm cheap and I don't like to pay for apps, and I have it. So I'm pretty sure that it's free. And so when you open it, the nice thing that I like about this is that it gives you the clinical information so that you can make a good decision. So LexiComp often is pretty generic, because to a fault, because it may not have specific studies, but Liverpool will update this with specific studies that have looked at it from a safety standpoint, so that you can make that decision. So what you do, the first screen is going to be the DAA that you're going to select. And then you start adding in the patient's medications. And as you add medication, then when you go to the results, it'll show up similar to what it looks like on the screen here, where it'll be red for do not co-administer. There's usually a yellow for a precaution, and then green where we don't have any major concerns with those agents. And the best part, as I alluded to, is that if you click on, whoops, oh, backwards, too soon. When you click on this, it'll give you the specific information that you saw. So what was the concentration, increase, decrease? What were those studies? So that you can make a clinical decision about it, rather than something like LexiComp, which will give you theoretical interactions, but maybe not that specific information. So something on LexiComp, it may say, don't co-administer, this is a bad idea. But then when you look at this information, you can say, well, it does have the interaction, but in the studies, it wasn't a big deal. So I'm okay if the patient continues on that. So it's a nice resource to have. Like I said, it's an app, so you can have it on your phone in your pocket, and it is pretty easy to use. All right, now I'm done. I'm happy to take any questions.
First, I just want to say thank you again, Rachel, so much. Those are wonderful slides, great resources, and we'll definitely have those in the content. So appreciate you taking the time to do that. Does anybody
Sure.
have any comments or questions?
I just want to say thanks, Rachel. You're awesome. You just are so
Oh.
thorough and you just explain it so well. So I appreciate you going through that with everybody.
Sure, happy to do it.
I agree with that. I mean, it's just a nice resource to have, and it's something I can share your slides with colleagues too, because we're getting more Hep C, so and HIV, so we need to be aware of all this stuff.
Yeah, and if there's ever anything you guys say like, hey, that's why I put more of the psych meds in here, because I have done this talk several times, and I'm always trying to add stuff in there that you guys want me to highlight. So if there's ever anything that you think like that would have been good to be in that drug interaction slide, let me know. I'll add it.
Rachel, thanks. This is John, also known as Don. I wanted to tell you, you might have introduced a new favorite word to me, and that's the word commandeer. I'm going to commandeer the use of your word commandeer. That's underutilized, man. I'm excited, but amazing as always. Appreciate your education to us and your availability when I forget everything you taught us. So
Thank you.
I got my use of commandeer, I'm pretty sure, from Pirates of the Caribbean.
That's epic. I love that. Anyone else before I go into announcements?